Okay, so we're going to go on to the shoulder examination now. So again, this just starts off with a good overall inspection of the patient. I'm looking for symmetry of the shoulders, muscle bulking, especially around the trapezius there. Is there any sloping of the shoulders? And just general biomechanical appearance and on the back. So I'm going to get you to walk up and down for me, again assessing gait, and come back for me. And I'd like to assess the kinetic chain. So are you able to do a one-legged squat for me? Try and bend to 90 degrees. I'm looking for rotation of the knee, any pelvic dipping. Is the patient able to do it? Okay, before we move on to the shoulder examination, I'd like to just clear the C-spine. So I'm going to ask the patient to do some movements. So can you touch your chin to your chest for me? Good. Look up at the ceiling. Good. Can you touch your chin to your left shoulder? Chin to your right shoulder? Ear to your left shoulder? Ear to your right shoulder? Okay, good. Any neck pain at all? I'm going to have a feel of the C-spine as well. Any pain at all when I'm palpating down? No. Okay, and any numbness or tingling in your arms at any stage? No. So I'm happy that the C-spine is cleared there. I'm going to go on to a closer inspection of the shoulder. So are the pec muscles equal? Again, have a look at the trapezius, the deltoids, any muscle bulking, wasting, and again have a look at the back for any obvious scapular deformities such as winging. At this stage I'm going to have a look, palpate the joint. So I'm going to start off at the sternum, have a feel of the sternoclavicular joint, palpate along the clavicle, along to the AC joint, and then further down on the acromion. Any pain there at all? No. I'm going to have a feel of the bicep tenderness as it attaches to the acromion, and also the pec tendon in the axillary crease. So I have a good palpate there. And I'm also at this stage want to palpate from behind as well. So I'm going to start off at the posterior edge of the acromion. This typically would be tender in a slap lesion. Have a feel across the spine of the scapula and the medial border of the scapula as well. Also from behind I want to look at muscle wasting, in particular the supraspinatus and infraspinatus muscles. Is there any wasting there? Okay, so I've had a feel of the joints and palpated. We'll want to go on to movements now. So could you actively move? So I want you to lift both your arms up and as high as you go. So that's flexion, and then back down for me, and extend your arms back as well as far as you go. Okay, rest back down. At this stage I want to have a look at behind. So can you point your thumbs up your back as far as you can go? So both. So again I want to have a look at the level of that, and we're assessing internal rotation there. Okay, great. So hands by your side for me and elbows by your side, and I want you to do that for me. So that's external rotation and then across, internal rotation. Okay, great. And then hands down by your side, and also I want you to abduct as high as you can go and then back down. Okay, and I'm going to just have a look at that from behind as well. So do that again for me. In particular, and pay attention to the scapular movements there. Are they symmetrical? Is there any scapular dyskinesis obvious that I can see? Okay, so I'm going to do that passively for the patient now. So I'm just going to stabilize the scapula. As soon as I feel that move, I'm going to stop. So I'm assessing for flexion, abduction, and I'm going to externally rotate. Good. internally rotate. So about 90 degrees external rotation, maybe about 70 or 80 of internal rotation. Okay, good. So I've done my movements now. I want to again just go back to the scapula and just sort of assess the movements of the scapula now. So can you shrug your shoulders for me? Good. And then shoulders down as far as you can go. Great. So that's superior and inferior movements of the scapula. I want you to shrug your shoulders forward for me. So that's pronation of the scapula, and shrug your shoulders back for me. Okay, so that's protraction, retraction of the scapula. Great. In particular, I'm paying attention to the distance of both the medial border of the scapula to the spine. I'm going to measure both of those. Any distance greater than 1.5 centimetres would signify scapular dyskinesis on that side. Okay. And again, can you just abduct your arms? And again, looking for the all the way up for me. Okay, and back down. Again, I'm looking for scapular rhythm there. Okay, so I'm satisfied with my movements. I'm going to test for the AC joint now. So again, I'm going to have a feel of the AC joint, and I want you to put your arm over there like a scarf. Okay, and that's going to create pressure on that joint. If there's any pain there, then I'm worried about AC joint pathology. So there wasn't any pain or impingement there. Okay, so I want to go on to restricted movements now. So can you just face towards me? I want to test the deltoids first, so put your arms out there for me. Don't let me press down, so keep them up. So I'm looking at power of the deltoids there, which I'm happy with. Put your arms down, put your arms up, and in particular, I want you to, so uppercut. And again, I'm looking for the bicep power on both sides. Excellent, good. So I want to go into restrictive movements, which can also look at the rotator cuff. So elbows by your side, and I want you to push out against my hand. Okay, good. I'm looking for any power or pain or weakness there, and that's looking at infraspinatus and teres minor. And I want you to push, same position but push in. That's looking at subscapularis. Another test for subscapularis is turn around for me. Put your hands out there like that there for me, and then push against my hand. So push out. Good. So again, looking at any weakness for subscapularis. The supraspinatus rotator cuff is the most commonly affected. So we're going to do the empty can test there. So I want you to flex your arm out for me. Great. And then I want you to turn your hand over like emptying a can and push up for me. If that causes any pain or weakness, that's supraspinatus pathology. Okay, and then hands down for me. Okay. So once having done restrictive movements, I want to look at impingement now. So the near test, again, is looking at impingement. So I'm going to try and press that acromion, and can you flex your arm? If there's any pain there, that signifies that impingement could be a possibility. Another test for impingement is the Hawkins-Kennedy test. So face me, right arm to right arm. I'm going to just, again, pinch that acromion, and I'm going to internally rotate that shoulder and try and exacerbate the pain, looking for impingement there. Okay, so once having looked at impingement, we're going to go on to looking at slap lesion. Again, we had a look at behind and had a feel of that posterior aspect of the acromion, which is tender, but also we can do O'Brien's test. So O'Brien's test is face this way. Can you flex your arm for me, and then adduct the arm slightly. Again, hands down. I want you to push up on my hand. If there's any pain there, that signifies that there could be a slap lesion. But with the thumbs pointed up, if that improves things, and keep pushing up on my hand, that also signifies that there could be a slap lesion, as it's easier to do that. The final aspects of the shoulder joint are stability of the shoulder joint. So if you could face me, the first part of that is to look for the sulcus sign. So I'm just going to inferiorly stress the shoulder joint to see if we can see any sulcus there. I'm going to also do a drawer test, so stabilise the scapula and try and stress that glenohumeral joint to see if there is any laxity. And finally, if you could lie down for me, is to look at the apprehension test. So you want to have the patient lying on the side of the bed. You want to abduct and externally rotate the shoulder, and then you want to externally rotate and stress that. You can also have your hand behind the shoulder and try and anteriorly stress that glenohumeral joint. If there is any worry about instability, the patient's going to be jumping up off the bed. You can try and posteriorly stress that down to relieve that instability there. Okay, so that completes the exam.